Hello, welcome to my channel. So today we are going to be talking about a case study. So this case study will be specifically for ectopic pregnancy. So the questions for the case study. So this is the questions for the case study, and the answers are going to come after we go through the topic ectopic pregnancy. So expect answers at the end of the presentation. So the questions: what's your diagnosis? What are the usual presenting symptoms? Mention 2. What are the risk factors for this condition? What is the medical treatment? What is the surgical treatment? Okay. So in terms of literature wise, so ectopic pregnancy is any pregnancy that is implanted at a site outside the uterine cavity. So it's an abnormal kind of abnormal implantation. It's an abnormal implantation. Okay, outside the uterine cavity. Then in terms of risk factors, we can have past medical history of previous ectopic pregnancy, PID, which is pelvic inflammatory disease, so due to adhesion formation. Then endometriosis, also due to adhesion formation. Then the other risk factors, we can have contraception, so intrauterine device or intrauterine system. So this itself, in a sense itself, so uh, in a sense in itself, this factor is not necessarily that when someone is using the contraception they're going to have ectopic pregnancy, but the failure of the IUCD is the one which is not going to make someone to have an ectopic pregnancy. So if the IUCD fails in preventing someone to become pregnant, so when it fails and someone becomes pregnant, that's when they are going to have the ectopic pregnancy. Because if it's working properly, then someone can't become pregnant. But the failure, okay, then of course even this also applies to progesterone, oral contraceptives, implants. So due to fallopian tube serial dysmotility, then tubal ligation. Okay, so those are some of tubal ligation or occlusions. Okay, so those are some of the things you have to talk about. Okay, then for iatrogenic, we can have pelvic surgery, especially tubal surgery or removal of sterilization. Also assisted reproduction, that is embryo transfer in IVF. Then you also have to note that the use of contraception actually reduces the rate of pregnancy. However, if there is failure of the contraception types below, if the contraception types, then the pregnancy is more likely to be ectopic. So that was what I was explaining. Um, that was what I was explaining on the IUCD and even the other types of contraception. Okay, it's a failure of the contraception that makes someone to more likely have an ectopic pregnancy, not necessarily the use itself. Then in terms of the common sites, so the common site, of course, we have the fallopian tube. Then again in the fallopian tube, you should also include the common site, such as which is the ampulla. Okay, then following the isthmus of the fallopian tube. Then less commonly we have outside the fallopian tube, uh, the ovaries, cervix, and peritoneal cavity can also be involved. Okay, these are some of the things you have to look at. Okay, so uh, a way to remember the the position someone can have an ectopic pregnancy in the fallopian tube. So the fallopian tube of the fibula, has the infundibulum, says says the um says the ampulla. It also has the isthmus. So fimbrial, infundibulum, isthmus, and ampulla. Okay, so maybe to simplify this, let me just put FIA. So fibula, isthmus, infundibulum, ampulla. So ampulla is the most common. Then since we have two eyes, so you can put either one. So either isthmus or infundibulum, but just remember that isthmus is the one which is the second from ampulla. Okay, so the most common site in the fallopian tube is the ampulla. Okay, so all these are parts of the fallopian tube. Okay, then clinical features, we can have a triad, so it's supposed to be triad. Of course, where we have lower abdominal or pelvic pain, which is the most common, so plus or minus vaginal bleeding or amenorrhea. So the triad is the three symptoms, so lower abdominal pain, vaginal bleeding, and amenorrhea. So that's the three symptoms which are common, but the commonest is lower abdominal or pelvic pain. Then you have to note that the vaginal bleeding in ectopic pregnancy is the result of decidual breakdown in the uterine cavity due to suboptimal beta HCG levels. Then bleeding from a ruptured ectopic pregnancy is usually intra-abdominal and not necessarily vaginal. Okay, so remember, it's not necessarily that someone has an ectopic and after it ruptures, then the PVB is a result of the suboptimal beta HCG levels, which is going to cause decidual breakdown in the uterine cavity. Okay, then other symptoms, of course, we have shoulder tube pain, which is just the irritation of the diaphragm by blood in the peritoneal cavity that leads to referred shoulder tube pain. Okay, of course, this is because the diaphragm and the supraclavicular nerves, which innervates the shoulder tube, shares the C3 and C3 to C5 dermatomes. Okay, that's the shoulder tube pain. Okay, so it's very good to remember this because we might even be asking an MCQ setup where they say the shoulder tube pain is as a result of irritation to what. So okay, then you may given some options there. Okay, then the other symptom is vaginal discharge, where we have a brown in color, classically described as being akin to prune juice, which is a result of decidual or breaking down. Okay, those are some of the things you have to bear in mind. Okay, then on examination, the patient may have a localized abdominal tenderness with a vaginal examination revealing cervical excitation or adnexal tenderness. Then if the ectopic pregnancy is ruptured, the patient may also be hemodynamically unstable. So there will be pallor, increased capillary refill time, tachycardia, hypotension, with signs of peritonitis, abdominal rebound tenderness, and gagging. Okay, then the vaginal examination may reveal fullness in the pouch of Douglas. Okay, those are some of the things someone might expect in someone who has ruptured. Okay, but there will be those who are ruptured and they are hemodynamically stable, meaning maybe the rupturing just taken place there and there. There will be those who come with a ruptured ectopic pregnancy and are hemodynamically unstable. Okay, then differentials, we can have a miscarriage. So a miscarriage can be any those spontaneous ones. Then ovarian cyst accidents, which refers to a cyst hemorrhage or torsion or rupture. Then acute pelvic inflammatory disease, urinary tract infection, appendicitis, diverticulitis. Okay, those are some of the differentials. Then investigations we can do. So a pregnancy test, which is a urine beta HCG, is the most important initial investigation for an ectopic pregnancy. So if positive, a pelvic ultrasound should be performed. So this can determine the presence or absence of an intrauterine, which is a normal pregnancy, if an intrauterine pregnancy is not seen on the transabdominal ultrasound. Then a transvaginal scan should be offered as well. Okay. Then if a pregnancy cannot be identified on ultrasound but the beta HCG is positive, this is termed a pregnancy of unknown location. So it has three main differential diagnoses. So one of them is for a pregnancy of unknown location. You can have a very early intrauterine pregnancy. The other one is miscarriage. Then the last one is ectopic pregnancy. So in this situation, a serum beta HCG should be taken so that you know if someone is having a suboptimal beta HCG. Okay, then after you take the beta HCG, if the initial beta HCG levels is more than 1,500 international units, which is the discriminatory level, and there is no intrauterine pregnancy on transvaginal ultrasound, then this should be considered an ectopic pregnancy until proven otherwise. Then a diagnostic laparoscopy should be offered. Okay. Then if the initial beta HCG is less than 1,500 international units and the patient is stable, then a further blood test can be taken 48 hours later. So in a viable pregnancy, the beta HCG would be expected to double every 48 hours. So this is another MCQ question. Okay, so in a normal pregnancy or viable pregnancy, beta HCG level doubles every after how many hours? Okay, then in a miscarriage, the HCG level would be expected to have every 48 hours as well. And then when the increase or drop in the rate of change is outside these limits, an ectopic pregnancy cannot be excluded and the patient should be managed accordingly. Then other investigations should be used as appropriate to rule in or rule out the other differential diagnosis, e.g., urinalysis for urinary tract infections. Then in terms of management, so any patient with a suspected ectopic pregnancy should be admitted to hospital if unstable and an A to E approach should be used to resuscitate the patient. So this may include the use of blood products if these are signs of hemodynamic instability. Then the definitive management of ectopic pregnancy should be medical, surgical, or conservative. Okay, so when do we do medical? So medical management of an ectopic pregnancy is with IM methotrexate, which is an antifolate cytotoxic agent that disrupts the folate-dependent cell division of the developing fetus. And then the pregnancy will then gradually resolve. So the serum beta HCG is monitored regularly to ensure that the level is declining by more than 15% in day 4 to 5. And if there isn't such a decline, a repeat dose is administered. So for medical management, it is offered to patients who are stable, that's one, with well-controlled pain, then also with a beta HCG levels of less than 1,500 international units per mil. Then if the ectopic should be ruptured, the ectopic itself should be unruptured. That's also the most important indication, and without a visible heartbeat. So the patient should have access to a 24-hour gynecological services and be informed of the symptoms of rupture. Then advantages for medical is that it avoids the complications of surgical management and the patient can be at home after the injection. Then disadvantages, so the potential side effects of methotrexate such as abdominal pain, myelosuppression, renal dysfunction, hepatitis, teratogenesis. So where the patients must be advised to use contraception for 3 to 6 months after methotrexate use. Okay, then the patient can fail, which could necessitate so the treatment can fail, which would necessitate surgical intervention. So it's not always that when you start medical we're going to work out. Okay, just pending, because we might touch today, then after just maybe after starting the interruptions, then of course you have no choice just to do surgical intervention. Okay, then for surgical, it involves the surgical removal of the ectopic pregnancy. Then in cases of ectopics, which is the most common, a laparoscopic salpingectomy is usually performed, removing the ectopic and the tube that it is implanted in. However, if there is damage to the contralateral tube from infection, disease, or surgery, a salpingotomy, which is a cut in the fallopian tube, so salpingectomy is removing the tube as well, is cutting and removing the tube. But if there is damage to the contralateral tube, you can't necessarily just remove the tube whilst the other one is having an infection or a disease. Okay, so that one we have to do salpingotomy, which is a cut in the fallopian tube, which is going to be performed to remove the ectopic and salvage the tube to preserve fertility. Okay, then you have to note that in salpingotomy, the HCG follow-up is required until the levels reach less than 5 international units, which is a negative state. Then to ensure there is no residual trophoblasts, the risk of recurrent ectopic pregnancy in the salvaged tube will be increased. Okay, then surgical management. So for surgical management, it is typically offered to patients with severe pain and a serum beta HCG of more than 5,000 international units per mil, and adnexal mass more than 34 millimeters, which is more than 3.4 centimeters. So more than 3.4 centimeters, and or fetal heartbeat at visible on scan. So that's why even for medical management, you find that they even put the opposite to say when someone is having an adnexal mass of less than 3.5, you can do medical management. Okay, just twisting the indications for surgical management. Okay, so if the adnexal mass is more than 3.4 centimeters, also this one is going to indicate surgical management. But if it's less than 3.5, then you have to take it to the medical, but you also have to follow other indications thereof. Okay, then advantages for surgical management, of course, we have reassurance about when the definitive treatment can be provided. There is a high success rate. The disadvantages, we have general anesthetic risk, which is the risk of damage the neighboring structures like the bladder, bowels, ureters, DVT or pulmonary embolism, hemorrhage, infection, and also of course to note that with salpingotomy, there is also a risk of treatment failure, as some of the pregnancies may remain within the tube. Okay, then all rhesus negative women who receive surgical management of an ectopic pregnancy should be offered anti-D prophylaxis. Of course, one of the other disadvantages, of course, for an rhesus negative women is that in our setup, the anti-D is actually expensive. Okay. Then for a tubal pregnancy, it's going to terminate in a number of ways. So it can either terminate in absorption, where in a few cases it is possible that absorption of a very early tubal pregnancy occurs. Then the embryo dies in the tube with a small amount of bleeding and is partly absorbed. Then the next way is tubal abortion, which is part of the product of conception are expelled from the tube in the peritoneal cavity. Then we have the most common, which is the most dramatic and the most common, and which is the tubal rupture. So this is the most dramatic and best known termination of a tubal pregnancy, although in fact less common than absorption or tubal abortion. But remember, since these ones we don't necessarily monitor them, so it's very difficult for someone who had a tubal pregnancy that are absorbed or that are aborted to monitor, like to know if they actually had that one. But most people will come and find that they just come with a ruptured ectopic pregnancy in practice. Okay, so in short, data-wise, it's in fact less common than absorption or tubal abortion. But clinical-wise, we find that you're actually going to see more patients with tubal rupture than those ones with abortion, tubal abortion, or absorption. Okay, so there is an acute intraperitoneal hemorrhage from erosion of an artery. Then the pregnancy is often implanted in the lower isthmus of the tube. Then we have the last one, which is secondary abdominal pregnancy. So this is the rarest outcome of all, where the embryo is expelled complete from the tube and acquires a secondary attachment in the peritoneal cavity. It can occasionally go on a full-term abdominal pregnancy, and this actually have happened before. You can even watch videos and the research on how they were extracting a secondary abdominal pregnancy baby. Okay, then that's all on the literature review. So for the case study answer, so the diagnosis of course is ectopic pregnancy. Then the usual presenting complaints, we just use the triad, this is the lower abdominal pain, vaginal bleeding, and amenorrhea. Then we have the risk factors for this condition. We have previous ectopic pregnancy, history of PID, salpingitis, endometriosis, tubal pregnancy itself, or uterine myomas, adhesions, and abdominal uterine anatomy. Then even the failure of the use of IUCD. Then medical management, of course, methotrexate. Then surgical management, we have salpingotomy and salpingectomy. So that's the end of the presentation, and thank you for watching. If you haven't subscribed, please subscribe to my channel and share this video, and give us a like. But give us a like and comment in the comment section. Okay, see you on the next tutorial.